All right, now let's talk about how and where these cardiovascular agents, how do they target and which molecules they target. So let's start from here. So we have a GQ agonists. GQ agonists are going to be epinephrine, norepinephrine, endothelin, high yield, angiotensin 2, and vasopressin. They're all GQ. And you all know how GQ works. When these drugs bind to the GQ causes increase in IP3 or stimulation of IP3 pathway, and that stimulates the calcium from sarcoplasmic reticulum to release the calcium from sarcoplasmic reticulum, and that calcium goes out. That calcium causes what? It binds to the calcium colmetalin complex. So it binds to that, and that causes stimulation of MLC kinase, which is myosin light chain kinase. So now let's look at some mnemonics here for this thing. Let's actually zoom in. So what are we saying here? All we are saying is, okay, IP3, we all know it releases calcium, right? So calcium starts from C, so it's going to bind CCC, calcium colmetalin complex, and that is going to stimulate MLC kinase. So instead of calling it from kinase K, call it kinase or sinase, something. Kinase, because the other guy is going to be MLC phosphatase, which is different. Okay, so here, what we have is we have kinase. Okay, for C, calcium stimulates the kinase. That's important. And what is kinase going to do? Well, kinase is going to put, you have a myosin, it's going to put that phosphate on the myosin, and that's going to cause contraction. And what is contraction going to do? That's going to cause, for example, if it's smooth muscle or if it's a vessel, it's going to contract that vessel, right? So vasoconstriction of that vessel. And what are the things that we're doing it? Okay, you had epinephrine, norepinephrine on alpha 1 receptor, endothelin, angiotensin 2, and vasopressin. All of them are working through this pathway. Now look at the other pathways. Let's just look up their GI or GS. GI pathway, which is inhibitory pathway. Also, you have epinephrine, norepinephrine, which are working on alpha 2 receptors. And GI, if you look, it's when you activate the GI, they will inhibit adenylate cyclase, right? And that is, this pathway will not work. So let's look at GS. That what was this pathway doing? If you stimulate the GS, you stimulate adenylate cyclase, which is going to convert the ATP into cyclic AMP, high yield. So the mnemonic here is going to be A and A cyclic AMP. Adenylate cyclase activates CAMP, right? And then you have after CAMP, that's going to go and form PKA, and that would inhibit the phospholambands. Phospholambands, what were normally phospholambands were doing? Look, phospholamban normally was inhibiting the SERCA. And what was SERCA doing? SERCA was allowing calcium to come inside, right? And when you have calcium here, right, it's going to cause decrease in cytosolic calcium that will lead to relaxation. Okay, so when you inhibit phospholamban, you are inhibiting the whole thing, and you will have vasodilation. I hope you're getting what I'm trying to say here. But what we have to now remember, now important thing that they will ask you pretty much will be adenylate cyclase, cyclic AMP, and your PKA. Okay, that's these three things are important. A for adenylate cyclic, cyclic AMP, PKA, and phospholamban. What are the drugs that are GS? Those are your epinephrine and beta 2 receptor, prostaglandins, prostacyclins, phenoldiprem, and D1 and adenosine. Okay, and that is going to be all. And you have a direct drug which would inhibit your PDE3, that is that was destroying the cyclic AMP into cyclic AMP into AMP. So when you inhibit this molecule here, when you inhibit this enzyme, what's going to happen is you are increasing cyclic AMP and leading to relaxation, okay, indirectly. And these are PDE3 inhibitors, which is melrenin, okay. And what else you have? If you look on the bottom side, let's actually look here since we were talking about CCBs. So let's talk about CCBs here as they work with calcium. CCBs, and we will go in details on all these drugs. This is just a summary sort of a thing. Okay, so in CCBs, dihydropyridine calcium channel blockers, amlodipine, clevidipine, nicardipine, nifedipine, nimodipine, they are all inhibitors of L-type voltage-gated calcium channels. Okay, when you inhibit that, normally what's happening here is calcium is coming inside, and that calcium is forming that complex, what they call metalin, and stimulating MLCK kinase, right, leading to contraction. But now when you're inhibiting this thing, so nothing is going to work. So CCBs, and this is specifically these L-type calcium channel blockers, they're going to work in the cardiovascular muscle, cardiac muscle. Okay, now we talk about the other side of this, which is, let's change color. Let's talk about the receptors on the vascular lumen. We have receptor for acetylcholine, alpha-2, bradykinin, cytokines, histamine, serotonin, shear stress. All of these things would act on their receptors on the lumen of the vessel, and that when they act, they release calcium. When calcium, again, everything is about calcium. Calcium causes nitric oxide synthase. It stimulates NO synthase. What is NO synthase? Nitric oxide synthase doing? It's converting arginine to nitric oxide. So in other way, you can say all of these are stimulating nitric oxide somehow. Okay, and that nitric oxide is going to diffuse back into the smooth muscle cell. Okay, with the smooth muscle cell, you have diffusion of this nitric oxide. Now you can get directly that nitric oxide within the smooth muscle if you give nitrates from outside, right? Or the other way you can do is in the bacterial LPS, lipopolysaccharides, they also release that enzyme, nitric oxide synthase, which forms nitric oxide within the muscle cell. So now once we have this nitric oxide, so just remember all of these factors, nitrates or bacterial wall or LPS, they're all giving us nitric oxide. Now what is nitric oxide doing? Well, nitric oxide is stimulating guanylate cyclase, and that is going to convert GTP into cyclic GMP, high yield, okay, GMP, and that is going to stimulate MLC phosphatase, myosin light chain phosphatase, which the whole action is that it's going to take out that phosphate bond, causing relaxation of the muscle. Okay, and that's how. So in a nutshell, we said calcium would contract, C for C, and nitric oxide would relax. And there are so many factors which come in the role of causing this, letting this calcium come inside the cell, right? And there are so many other factors which cause nitric oxide to come inside the cell, and that is what we have. Now on top of that, we can, same thing as melrenin, here we have PDE5 inhibitors, which would inhibit this right here, which is PDE5, which is converting cyclic GMP into its metabolite, which is GMP, inactive metabolite. So we stop this conversion by sildenafil to increase cyclic GMP. That would potentially cause relaxation, more time relaxation, right? And other than that, we have some ANPs and BNPs, which also directly stimulate the guanylate cyclase. So now high yield points in this is all about that you have to know nitric oxide deals with cyclic GMP. So maybe you can call it a no gap policy, no gap. no gap policy or something. No gap means nitric oxide, cyclic GMP, versus the other one is all about A's, cyclic AMP, adenylate cyclase, pKa. That's important actually. So with the nitric oxide is the GMP, guanylate cyclase, and all that. With the adenylate cyclic is AMP and pKa. And with the GQs, it's all about IP3, calcium, and all that. And that is all for this picture. Let's move on to the next one now. Okay, now the first drug in antihypertensives, we will be talking about calcium channel blockers. In calcium channel blockers, what do we have? So calcium channel blockers are amlodipine, clevidipine, nicardipine, nifedipine, nimodipine, which are all dihydropyridines, as they act on the vascular smooth muscle. Diltiazem, verapamil, they will verapamil are non-dihydropyridines, and they will act on the heart. So here's the thing that I have it up there. So just let me write verapamil. So here's the heart. Okay. And here's all the vessels. And these are also the vessels. So verapamil specifically acts on the heart, while diltiazem works on heart as well as vessels. And dihydropyridines, which are all the rest of these ones, they will all work on the vessel. So verapamil, if someone talks about verapamil, is specific to the heart. Verapamil, specific to diltiazem, both heart and vessels. Dihydropyridines, meaning anything else that you see, is going to be just the vessels. Okay, now let's talk about the mechanism of action for CCBs. So CCBs, they block voltage dependent L-type calcium channels for cardiac and smooth muscles. So no skeletal muscles, right? Because skeletal muscles, they do not depend upon L-type calcium channels. So only the cardiac and smooth muscles in which you have L-type calcium channels. And that causes decrease in muscle contractility. When you decrease muscle contractility, again, what are you causing? Relaxation. Dilation, right? So vasodilation. Let me erase this. So vasodilation. Now, there are two things, right? We talked about two drugs, dihydropyridine, non-dihydropyridines. So vascular smooth muscle, which are amlodipine equals nifedipine, nifedipine is greater than diltiazem, verapamil. We talked about it right now, just up top. Verapamil, just think about heart. V for like a heart. Verapamil is a V, which is a heart. Diltiazem, it's everything. And all the rest of CCBs are just the vessels. Okay, now again, they're going to tell you the same thing. Heart, verapamil, greater than diltiazem, greater than amlodipine, equals nifedipine. You know this, and you're good to go. Okay, then you have clinical uses. Well, actually, before clinical uses, let's talk about the mechanism. So what are they doing on the vascular smooth muscle, and what are they doing on the heart? Two things, right? So vascular smooth muscles, they are causing it to relax. So arteriolar vasodilation, and that leads to two things. That leads to decrease in afterload, right? Because when you dilate the arterioles, you're decreasing the afterload. And systolic blood pressure would also decrease, right? Because decreasing afterload is going to decrease the systolic blood pressure. Now, on top of it, the other thing they would do is this vasodilation would be dilation of the precapillary vessels. Dilation of precapillary. Let me erase this and zoom in. So dilation of precapillary vessel. And why is that important? Because when you dilate the precapillary vessels, what's going to happen here is that this is going to cause increase in, when you dilate, this is going to increase, it's going to cause increase in hydrostatic pressure, but you don't have to memorize that. Just remember, it's going to cause, because you dilate, the precapillary vasodilation occurs, it's going to cause edema, peripheral edema. This is what you need to remember. Peripheral edema. Okay. Now let's compare and contrast that thing. Okay. So they are dilating the precapillary, right? And RAS inhibitors are causing post-capillary vasodilation. Post-capillary vasodilation that leads to that will normalize the hydrostatic pressure, and that will lead to decreased risk of peripheral edema in patients taking, decreases the risk of peripheral edema. So this is another high yield point, but what is most high yield, or what is really important to know, is the first part, which is these CCBs would dilate the precapillary, causing peripheral edema, and we will see that in the adverse effects. Other than this, what we have is clinical uses. Let's talk about these now. Okay, wait, we didn't talk about the heart. So we just talked about vessels here, but the heart. What is it doing on the heart? Well, it is causing negative inotropy, negative chronotropy, and negative dromotropy, which basically means decrease in heart rate by decreasing SA and AV nodal conduction, by decreasing phase 0 depolarization. And if you recall that phase 0 depolarization, which was like this, and if you decrease this phase 0 depolarization, you would not reach the threshold that the L-type calcium channel opens, which causes the depolarization. So if you recall, we did that in physiology. You can take a look at that lecture again. It's a pretty good concept that phase 0 depolarization would cause decrease in SA and AV nodal firing. Okay, that's a very high yield concept. But this is all about the heart and the vessel. Now let's look at the clinical uses. Dihydropyridine, except nimidipine, causes clinical uses. It is used in hypertension, angina, including vasospastic angina, Raynaud phenomena. Dihydropyridine mainly dilates arteries, right? That's what we have been saying. Vessels, right? Arteries, arteriolar vasodilation and all that. So arteries. So dihydropyridine dilates the arteries, while nimodipine, high yield, and you will see this in CNS. Nimodipine is used in subarachnoid hemorrhage. Why? Because it's going to prevent cerebral vasospasm. Nimodipine. I don't know if you can recall, there is a movie named as Finding Nemo, right? So just remember Nemo, Finding Nemo. Nemo is a fish, which, that fish is a very small fish, and she swims in water. That's all she does, right? So here, subarachnoid hemorrhage is like a water for a fish, right? I'm just trying to make a mnemonic here. If you have a better mnemonic, great. Please share with me as well. But to remember something, Nemo, that fish, she wants to again swim in the water. So what is a hemorrhage here is like a water for fish. Although it's a blood, but it's a water for fish. So nimodipine is used in subarachnoid hemorrhage. That fish loves to swim in the water, which is a blood here. So other than that, if you have nicardipine, clevidipine, used in hypertensive urgency or emergency, non-dihydropyridines, hypertension, angina, AFib, flutter. Okay, adverse effects, high yield. There are gingival hyperplasia. Dihydropyridines would cause peripheral edema. We talked about right there how you would cause the peripheral edema, right? Flushing, dizziness, other thing. But peripheral edema, main high yield adverse effect. Non-dihydropyridines will be having adverse effect as cardiac depression, right? AV blocks, hyperprolactinemias, verapamil specifically, and constipation. And why would we have hyperprolactinemia? Because due to the fact that due to calcium, the inhibition of calcium dependent dopamine release. So this calcium inhibition of calcium dependent dopamine release, because you're inhibiting the calcium, you're inhibiting the dopamine release. When you inhibit the dopamine release, there's decreased dopamine. When you have decreased dopamine, it's going to cause increase in prolactin. We'll talk about that in endocrine. So remember just one thing: when you decrease dopamine, there is going to be increase in prolactin, high yield again. But we will talk about it in endocrine. Hyperprolactinemia, and what else you might have. One thing they haven't mentioned here is called reflex tachycardia. Reflex tachy. So what is reflex tachycardia? So when you dilate, when you have a peripheral vasodilation, let's just write it here, peripheral vasodilation, right? What's going to happen is, with peripheral vasodilation, there's going to be decreased amount of blood coming in, because it's all vasodilation. The blood is going to be pooling, right? When the blood pools in, less amount of blood comes in, so the sympathetic nervous system gets on, and that stimulates the heart, causing reflex tachycardia. But how can you stop that? Well, simple thing: to avoid or to prevent reflex tachycardia, you can administer beta blocker. What is beta blocker going to do? Well, it's going to inhibit the heart to go into contraction, more contraction, and increase the heart rate. Again, tachycardia, right? We will inhibit the tachycardia by giving beta blocker. Okay, but where do we see which drugs do we see this reflex tachycardia with specifically? Dihydropyridines, because these are the ones which are causing. We will see a reflex tachycardia here. With non-dihydropyridines, very little. There is a less chance of getting reflex tachycardia, but with dihydropyridines, reflex tachycardia, because they are causing vasodilation, peripheral vasodilation. Okay, what else we can have? We did talk about a treatment for peripheral edema, right? We said, how do you treat why? Okay, well, let's talk about the cause here, since it's already here. So the cause is, again, you have a pre-capillary dilation that causes what? Increase in your hydrostatic capillary pressure, and that causes edema. To treat it, you can treat it by giving RAS inhibitors. Okay, and that is going to be all for CCBs. Let's talk about now hydralazine. Hydralazine is going to be hydralazine. Let's talk about this here. AA, right? Arterioles, specifically, greater than veins. Okay, the mechanism is simple. Hydralazine binds. Remember that nitric oxide we talked about? So hydralazine, first of all, is that it is an oral direct arterial vasodilator. That's an important thing to mention. Which binds on receptor on endothelium. Binds the receptor on endothelium, leads to nitric oxide release. That nitric oxide causes what? Stimulation of guanylate cyclase, and that causes increase in cyclic GMP. That when you increase cyclic GMP, what are you going to cause? You're going to cause arterial smooth muscle relaxation, right? And if you want to see that picture back again, here's the one. So nitric oxide, and that causes what? Relaxation. And it's a drug that you give from outside. Okay. Hydralazine arteriole has specificity for arterioles more than veins. So it's going to affect the afterload. So afterload would decrease because you're dilating the vessel. So afterload would decrease, right? And then what else you might have here? Clinical use with severe hypertension and particularly acute severe hypertension, heart failure with organic nitrates. It is safe, high yield, safe to use in pregnancy. Frequently co-administered with beta blocker to prevent reflex tachycardia. Again, same thing we talked about above. To prevent reflex tachy, you can give beta blocker. Adverse effect for hydralazine or compensatory tachycardia, contraindicating angina, CAD, coronary artery disease, fluid retention, headache, angina, and drug-induced lupus. High yield. So it is one of the cause of drug-induced lupus, which is a high yield thing. So what else? What other drugs would cause drug-induced lupus? They are isoniazid, procainamide, and hydralazine, as we talked about it. So yeah, that is going to be all for this drug. Now let's just review hydralazine quickly. Okay, it's a vasodilator which would dilate the artery, right? Simple thing, by causing nitric oxide, increasing cyclic GMP. It is safe in pregnancy, high yield, and it is contraindicated as angina and coronary artery disease, high yield. It causes fluid retention, which is again saying that you have. They will lead to peripheral edema. Okay, and what else you might have? SLE like drug-induced lupus, high yield point, and that is going to be all for hydralazine. One more thing is going to be hydralazine. As a nutshell, what is it doing? It's decreasing the afterload, right? And essentially causing what? With the dilation causing decrease in blood pressure. A decrease in afterload, decrease in blood pressure. And this decrease in blood pressure would trigger reflex sympathetic activity, reflex sympathetic nervous system stimulation. That reflex sympathetic, and you will also have stimulation of RAS, RAAS, my bad, renin-angiotensin-aldosterone system, right? So when you activate all of this, what's going to happen is you have two things now, right? With the sympathetic stimulation, with the sympathetic activation and RAS activation, RAS would specifically cause sodium retention, sodium and fluid retention. That would cause fluid retention, peripheral edema. And with the sympathetic stimulation, there's going to be reflex tachycardia. So with these factors in fluid retention, sodium retention, reflex tachycardia, these drugs are not used for long-term decrease in blood pressure, because you did decrease the blood pressure on the cost of what? On the cost of being reflex tachycardia, fluid retention, sodium retention, all of that. So if this is only used, so these effects affect much of its BP lowering activity, which will limit its long-term usage. So that is why we only use it for a little bit in severe hypertension or in pregnancy, and that is all for hydralazine. Now let's talk about hypertensive emergency, right? Hypertensive emergency. We can treat this with labetalol, clevidipine, phenoldiprem, nicardipine, and nitroprusside. And again, what was hypertensive emergency? When you had a blood pressure greater than or equal to 180 by greater than or equal to 120. Okay, for nitroprusside, this is short-acting vasodilator. Arteries equals vein, meaning it's going to dilate the veins as same way as it's going to dilate the arteries. Okay, increasing cyclic GMP while direct release of nitric oxide. Again, nitric oxide causes increase in cyclic GMP, but it's a direct because you're directly giving from outside nitroprusside, which contains nitric oxide inside, which contains NO, right? So directly increasing cyclic GMP, that but it can cause high yield is cyanide toxicity because nitroprusside is a complex of what? It's a complex of iron, cyanide, and nitrogen group. So it has cyanide inside. So that is why it can cause cyanide toxicity because it releases cyanide. Okay, and that is what we have. So one more thing is going to be for nitroprusside, as it is dilating the artery. So just guess what it's going to do. When you dilate the arteries, you are decreasing the afterload by due to the fact that you're decreasing systemic vascular resistance, right? When you dilate the veins, what are you doing for the veins? You're decreasing the preload. So decrease the preload, decrease the afterload. What is going to happen with these two factors in? When you decrease preload, decrease afterload, it's going to maintain the stroke volume and a cardiac output at a lower left ventricular pressure, because nothing much decrease in preload means not much is coming to the heart. Decrease afterload means heart can easily pump things out. So you're maintaining the stroke volume, pumping out, maintaining the cardiac output at a lower left ventricular pressure. Now let's talk about the other one, which is called phenoldiprem. Phenoldiprem, high yield, is again dopamine D1 receptor agonist. It causes coronary, peripheral, renal, splanchnic vasodilation. So coronary, peripheral, renal, splanchnic vasodilation. Decreases blood pressure, increases natriuresis. Also used post-operatively as an antihypertensive. Post-operative, after some surgery, you can give as an antihypertensive. Can cause hypotension, tachycardia, flushing, headache, and nausea. Also, it is used in one more thing is called hypertensive with renal insufficiency. So renal insufficiency. That phenoldiprem, first of all, it's a short-acting. It causes high yield point. It causes renal vasodilation. When you dilate the renal vein or renal vasodilation, meaning renal artery, when you dilate that renal artery, what's going to happen is that you have increase in renal perfusion. Increase in renal perfusion would lead to what? Increase in urine output, which is right here, increase in natriuresis. When you push out the urine, the sodium and urine goes out in together, right? The water, wherever the sodium goes, the water follows. You increase natriuresis by increasing the perfusion. Kidney thinks, okay, there's so much fluid coming in. It's going to throw out that sodium. When the urine throw out sodium, the water is going to follow. So increase urine output and increase in natriuresis. Sodium excretion, basically. And that is used in shock. So again, it's a protective methods in which there's a patient is in shock, and there's a chance that they can go into uh, prerenal azotemia. Then you dilate those vessels, those renal vessels, by giving phenoldipan, which is going to act on D1 receptors. That is going to dilate the vessels, would lead to renal perfusion. Renal can get perfused in a normal way. Okay, as I mentioned before, it is used in hypertension with renal insufficiency. Okay, and that is going to be all for phenoldipan. Okay, now let's talk about nitrates. Nitrates, the drugs are nitroglycerin, isosorbide dinitrate, and isosorbide mononitrate. Di means 2, mono means 1. Right? So mechanism, they will vasodilate by increasing nitric oxide. So nitroprusside is nitric oxide. Nitrate is also nitric oxide. Hydralazine, we talked about, also acts through nitric oxide. So all of them are working through main one thing, which is nitric oxide. So they increase the nitric oxide by the vascular smooth muscles, increase nitric oxide in the vascular smooth muscle, causing increase in GMP and smooth muscle relaxation. They would dilate the veins now. Now it's specific for the veins more than the arteries, high yield. Because it's specific for the veins, there will cause decrease in preload. Clinical uses are angina, acute coronary syndrome, and pulmonary edema. High yield angina, we use this for the angina and also in acute coronary syndromes. Adverse effects is reflex tachycardia. Why? Well, reflex tachy, you already know to treat with beta blocker. Methemoglobinemia, hypotension, flushing, headache, Monday disease is also high yield in industrial nitrate exposure. So what is Monday disease? In industrial places where people work in industries, right, there's a development of tolerance for the vasodilating effect or the action during the work week, and loss of tolerance over the weekend. It leads to tachycardia, dizziness, headache upon re-exposure. It is contraindicated in right ventricular infarction, hypertrophic cardiomyopathy with concurrent PDE5 inhibitor use. Okay. So what is important in all of this is, first of all, it's the mechanism of all the nitrates. So these nitrates, they increase nitric oxide, they work on the veins, decrease in preload. So when you decrease the preload, what's going to happen is not much blood is going to go into the heart. That's going to decrease the left ventricular and diastolic volume / pressure. Both of them will decrease, and that will high yield. This will lead to decrease in wall stress because it's not expanding anymore much. Meaning, normally if it is expanding this much, now you have decreased the end diastolic volume, so it's not expanding as much. So you have a decrease in wall stress, high yield. And that is why we use it in angina when there is already a wall stress. So this decrease in wall stress causes what? Decrease in wall stress leads to decrease in the oxygen demand, myocardial O2 demand, because you're not expanding as much, so you don't need that much oxygen now. And this decrease in myocardial oxygen demand will relieve the pain of angina, or will relieve the anginal symptoms, right? That is the one of the things that this drug does. The other thing is that because of dilation of the veins, it's going to cause let's change color. Veins is going to cause increase in venous capacitance. Venous capacitance, meaning the increase. It's going to keep the pull the veins within pull the fluid, which is the blood, within the veins, and leading to decrease in preload, and all of the things will be there. Okay, it has the modest effect in low dose and more effect with high doses. Okay, that's also important. With low dose, it's a modest effect modest effect. With the high dose, it is more effect with the higher dose on the arteries. So if you wanted to work just on the veins, what you do is you give in small doses. But if you wanted to work on the veins as well as arteries, you give in high doses. Okay. Let me erase this. One more point is going to be, they are all metabolized. These nitrates are metabolized to nitric oxide and S. We already know nitric oxide, right? And the new thing is S nitrosothiol. Okay, nitrosothiols, and we will talk about that. What that is going to do. On top of that, one more thing is nitroglycerin. In angina patient, we tell them to put that tablet under the tongue, sublingual administration. Well, why we do that? Because sublingual nitroglycerin will get absorbed quickly. Will get absorbed in the oral mucosa, venous circulation, which gives a rapid action. In about 2 to 5 minutes, it can start acting on the heart and all the veins and dilating all of that. While if you were to give this thing oral, let's say you give it oral, isosorbide dinitrate and isosorbide mononitrate, they have low bioavailability due to the extensive first pass metabolism. First pass metabolism. What is first pass metabolism? That you take a drug, when you give a drug, let's just do it here. You give a drug, it's going to go through GI, it's going to get absorbed through portal circulation, it's going to go to the liver. Okay, in the liver is going to destroy most of the drug, and that is called first pass metabolism. Whatever left gets back into the circulation, and this is your first pass metabolism. To avoid first pass metabolism, either what you can do is give straight up drug IV, straight up put in the vein, or what you can do is give the drug per rectum. Because if you recall, in the rectum below dentate line, the blood that it goes there, the venous circulation does not go back to the portal circulation. Instead, it goes back into the IVC, which goes straight to the heart, and which goes straight to the circulation. That's one of the things. Other than that, you can also give, as we mentioned here, sublingual, which is also going to go into the venous circulation straight and cause direct action. So that is another tie-in topic we did talk about as a first pass metabolism. That's in the journal pharmacology. Okay, what else we can think of while we are here? So here the contraindications high yield for this is the right ventricular infarction, due to the fact that these would decrease the preload, as you mentioned here, and that would impair the cardiac output. And when you impair the cardiac output, guess what can happen? You stimulate, again, sympathetic nervous system, and now you're already going into infarction, and you don't want the heart to pump more. So it is contraindicated in right ventricular infarction. Other than that, you also have with PDE5 inhibitors, because with the sildenafil, which is a PDE5 inhibitors, And this nitrates, they will lead to, if you give them together, they will lead to, because if you recall, PDE5 inhibitors is doing what? Increasing cyclic GMP. Nitrates are doing what? Causing nitric oxide, leading to increasing cyclic GMP. So these two together will potentially cause profuse hypotension. So that is why they are contraindicated with each other, and that is all for nitrates. So now let's just look at the anginal therapy, anti-anginal therapy. Anti-anginal therapy goal is to reduce, important point, we talked about this thing, myocardial O2 consumption, which is known as MVO2, myocardial O2 consumption, by decrease in one or more of the determinants of the MVO2. And that is either you decrease the end diastolic volume, you decrease blood pressure, decrease heart rate, or decrease contractility. So if you decrease any of these four factors, which is an important thing, end diastolic volume, blood pressure, heart rate, contractility, if you decrease any of this, you're decreasing myocardial O2 consumption. So let's look at the drugs that are beneficial or that are used for angina. So nitrates, beta blockers, and nitrates plus beta blockers. EDV and diastolic volume with nitrates is going to decrease, right? Beta blocker, it has no effect or even increase. When you give nitrate plus beta blocker, it has no effect or decrease. Okay, with blood pressure, both are decreasing, so both will decrease, right? Contractility, it's going to cause increase in contractility because there's a reflex. But guess what? There is no reflex here, so they are beneficial. But here the nitrates will cause reflex contractility and reflex tachycardia, which is heart rate. When you give them together, you will have no effect on contractility or no effect or decrease even heart rate, because the beta blocker would stop that contractility, as we talked about it. Ejection time will decrease in nitrates, but ejection time will increase with beta blockers. Give them together, no effect. Now, as a summary, what's going to happen with MVO2? MVO2 will decrease with nitrates, decrease with beta blocker, but if you give them together, you have a potentiation effect here. You have decrease in the myocardial oxygen consumption. And they're saying beta blocker is similar to verapamil. Verapamil is similar to beta blocker in effect. Okay, so that is there. So these are all the things that would decrease the myocardial oxygen consumption. Moving on with ranolazine. Ranolazine, it inhibits the late phase of inward sodium current, thereby reducing diastolic wall tension and oxygen consumption. Does not affect the heart rate or blood pressure. Okay, so all the mechanism of ranolazine is sodium current. So how can we remember that? So the easy way to remember that is ranolazine. Ranolazine, call it ranolazine. Na, sodium, right? Instead of nolazine, Na, and then there's L, right? So L for late. Or you can call lazy late, or you can just say L for late. So what is it doing? It's inhibiting sodium channel, which is ranolazine, but late phase of that sodium current. Okay, so that's the mechanism of action of ranolazine. So what does it do when you inhibit this late sodium current? It's going to reduce diastolic wall tension and oxygen consumption. When you reduce the wall tension, you are going to decrease the oxygen consumption. Does not affect heart rate or blood pressure. uses in refractory angina. Adverse effects are constipation, dizziness, headache, and nausea. Mechanism is important here, and that is all for ranolazine. Na again, summary: ranolazine, lazine, late, or L for late, sodium for Na, and that is it. Then you have sacubitril, Sacubitril, it's a neprilysin inhibitor that would cause what? That is going to cause increase in vasodilation, right? And that vasodilation would lead to decrease in the it is used in heart failure with reduced ejection fraction. So let's talk about this as a mechanism. Normally, neprilysin, it prevents the degradation of bradykinin, natriuretic peptide, angiotensin 2, and substance P. Okay, let me say one more time. Neprilysin, let's just do it like this so you know better what I'm saying. Neprilysin. Normal job of neprilysin is to degrade bradykinin, natriuretic peptide, angiotensin 2, and substance P. That's the normal job. So neprilysin degrades all of these things to inactive substances. Okay, now when we give, let's just change color here, we give neprilysin inhibitor, which is going to inhibit this thing, and that is the sacubitril. When you inhibit the degradation of all of these things, guess what's going to happen? You have all of these things that can be present, and they will cause their action. So bradykinin will be there, natriuretic peptides will be there, ANP, BNP, angiotensin 2 will be there, and substance P will be there. So now let's look at what are they going to cause. Well, all of these would cause vasodilation and decrease in extracellular fluid, ECF, extracellular volume, decrease in extracellular volume. Clinical uses: it is used in combination with valsartan, which is an ARB, to treat heart failure with reduced ejection fraction, ejection fraction. Okay, and adverse effects. All of these things will cause what? They will cause hypotension. They will cause hyperkalemia, cough, dizziness. It is contraindicated with ACE inhibitors due to angioedema. Both drugs increase the bradykinin. That is why you do not give ACE inhibitors with it. Okay. So now let's look at it one more time. Okay, now let's just go over what sacubitril. As a summary, sacubitril is a neprilysin inhibitor. Neprilysin degrades bradykinin, ANP, BNP, angiotensin 2, and substance P. Sacubitril inhibit this degradation by inhibiting neprilysin. And this all, when you inhibit neprilysin, these substances will lead to increase in vasodilation and decrease in extracellular fluid. And this is used in combination with valsartan. Valsartan is going to inhibit the role of vasoconstriction of angiotensin 2. Again, valsartan is ARB, angiotensin receptor blocker. Angiotensin 2, the deal of angiotensin 2 is it causes vasoconstriction. So you have to inhibit that, right? So you inhibit that, you give valsartan from outside. That's going to inhibit the vasoconstriction, causing the effect of vasodilation. On the other hand, ANP, BNP, all of them are causing vasodilation. The adverse effect is that you have vasodilated so much that's going to cause hypotension, hyperkalemia, cough, dizziness, contraindicated with ACE inhibitors. Why not? Because angioedema can happen, because both of these drugs are causing increase in bradykinin. ACE inhibitors increase bradykinin. Sacubitril increases bradykinin, leading to angioedema, so they are contraindicated. That's why we only use valsartan, which is ARB and not an ACE. And that is all for sacubitril. Then we have the next thing, and that will be another lecture.